Hello, I'm Dr. Vinod. I am a pediatric and adult laparoscopic surgeon who I'm a consultant in Dr. H.G. Rajaratnam Hospital, and I'm also a pediatric urologist in Coimbatore Kidney Center. Now I'm going to talk to you about a topic on urinary tract infection in children. Some others, wow, oh, children do get urinary tract infections? Yes, they do get urinary tract infections. Urinary tract infections, in fact, it is 1 in 20 children do get urinary tract infections. That much is common. And if you take into the sex differentiation in the boys and girls, girl children are more prone for urinary tract infections than men, than the boy child. The boy child, in that uncircumscribed children are more prone than the circumscribed children. So if you take, why do these children get into this urinary tract infections? That is annoying questions, right? So where do the organisms come from? The organisms doesn't live in the urinary tract system. Urinary tract system is completely sterile. It doesn't have any bacteria. The bacterial growth is around the genital skin and around the perirectal area. So the bacteria gets migrated into the urinary tract system and it leads to the urinary infections. So the urethra, that is the tube connect between the bladder and the outlet, it's called urethra. When that part is infected, it's called urethritis, and the bladder infected, it's called cystitis, and it goes to the kidney, it is called pyelonephritis. So do all the children are prone for this infection? No. Any children with any abnormality in the growth of the kidney systems, like any obstruction in the bladder to the urethra, you have a posterior urethral valve. It is in the male child, we see that. And if there is an obstruction, the urine doesn't come out of the bladder, so that it gets stasis into the bladder. So when the urinary stasis is there, it is prone for urinary infection. And next is any urine reflux into the kidney. The kidney flows urine from the kidney to the bladder and the urethra. So it should be a one-side flow. When the urine goes back into the kidney, it is called vesico-ureteric reflux. So this reflux system will leads to urinary infection and damages the kidney also. So when a child is having a VUR, they are prone for urinary infection. The third is any girl child having any tight inner garments, also they are more prone. And the children having a bubble bath, these are all normally we suspect the causes for the urinary infections. And delayed voiding in children also will cause. In school children, they don't void frequently. When they delay the voiding time, that also leads to urinary tract infection because there is a stasis in the system. So, okay, my child has a urinary infection. Okay, what are the symptoms I identify? Most of the time, children get unnoticed and automatically they get cured of urinary infections most of the time because we don't notice the symptoms. Because below 3 months of age, children also can get urinary infections when there is a congenital anomaly. So 3 months of children will not tell you that I have a urinary infection, I have any pain, I have a fever, nothing. So we have to pick up the symptoms. How do 3 months old children have a urinary infection? We will pick up. The 3 months old child will have fever or the child will be very lethargic, very irritable and poor feeding. The children will not take breastfeed appropriately and the failure to thrive. The weight gain will not be there. And apart from that, the urine might be cloudy, which we can find out. Urine will be cloudy or hematuria, that is blood in the urine. So these things we can find out when the child is below 3 years of age. And above 3 years and above 3 months, and the children, when they are able to communicate with you, the child will be complaining about dysuria, that is pain while passing urine, and incontinence. Sometimes the child present with a milder form of incontinence because they will be bedwetting in the school or in the night. These kind of symptoms also may be associated with any urinary tract infections. And apart from that, the major symptoms like fever, vomiting, malaise, and they will be complaining of lower abdominal pain. These are all symptoms of urinary infections. So once my child has been having a urinary infection and the symptoms are there, and what do I do with the urinary infection? What I have to do for further? The first and the foremost test what we do is an urinary simple routine examination. That is a very easy and it's a very non-invasive system of examination of the urine. So the urine routine investigations, what are you going to see whether there is a urinary infection or not? The first thing we usually see is the leukocytes. Normally the reports will come with the pus cells or leukocytes. The second thing is the nitrites. If pus cells or leukocytes and the nitrites are positive, it shows that there is a bacterial infection in the system. So we need to be evaluated. So once the urine routine shows that it is positive, then we have to do a urine culture. So for urine culture, the collection of sample is also very important, because very difficult to collect the urine samples from the children, because we can't collect it very sterile and it will be contaminated, because children they will not cooperate for the collection of urinary samples. So if the urine sample is contaminated also, then we don't get a proper report. The second thing is, if we are not able to collect it, we can pass in a needle suprapubically directly into the bladder and take it very sterilely, and we will send it for the urinary culture. And the sample should go immediately, that is within 4 hours it should reach the lab. If it is not so, you should refrigerate the sample and give it to the lab, because if you store it outside beyond 4 hours, that also gets contaminated. So once the urinary culture is positive, then how do I go? So if the child is less than 3 months, better to get admitted in a pediatric setup, because 3 months of the child, they go into sepsis, and they get worsened with these urinary infections. So we have to put the child on oral antibiotic. If required, if you suspect that is pyelonephritis, that is kidney system is getting infected, then you have to put the child on IV antibiotic, that is parenteral antibiotic. Child is older, that is above 3 months, and older children with urine culture positive and the urinary tract infections, simply we can manage with oral antibiotics. They respond well. If they are not responding, then we need to put them on parenteral antibiotic. All the urinary tract infections in children are very informative, or very serious, that we have to treat them. Single episode of urinary infections is not much. If you put on oral antibiotic, the child settles, nothing to worry about it. And if the children is having a recurrent episodes of urinary tract infection, yes, it is a very serious issue, and we have to evaluate the child. Once you have 2 episodes of urinary tract infection, the next about of the what evaluation we have to do is an ultrasound abdomen, just an ultrasound scan to know what is happening inside the systems. That is, we study about the kidney systems and the bladder and the urethra, and we see any dilatation of the system. That is more important. As I told you, the urine refluxes back into the kidney. So that once the backflow of the urine goes into the kidney, you get the dilatation of the ureter and the kidney. The system totally gets dilated. So it leads to hydronephrosis and hydroureter nephrosis. So when you find out in the ultrasound shows that there is a system dilatation, yes, then there is a problem. We have to evaluate further. We do a maturating cystourethrogram. Normally we call it as MCU. What is this MCU, and how about it? Is very invasive? No. It is minimally invasive, but it is invasive in the sense we need to trouble the child by passing in a catheter into the urethra. We pass in the contrast, and we pass in the fluids, and we fill up the bladder, and once the bladder is filled up, we will see whether the contrast is going back into the kidney or not. That will be picked up by an X-ray or fluoroscopy. So once the child is having a VUR, that is vesico-ureteric reflux, then we need to grade it. That is grade 1, 2, 3, and 4. So once the grading is done, that is grade 1 and 2 is a minimal dilatation of the ureter, kidney systems and pelvic caliper systems. So the grade 1 and grade 2, it is manageable conservatively, that is medical management. So once the system is clean, the urine is clean without any infections, there will not be any scarring in the kidney. So we need to put the child on chemoprophylaxis, and we have to follow up the child. That's it for grade 1 and 2. If the child is having grade 4 and grade 5, that is a high grade of reflux, then we need to see whether surgical intervention is needed for the child. If there is a reflux of more than 5, then we have to go for a reimplantation, or the cystoscopically guided, we can inject a deflux, that is a medicine we inject around the ureteric orifices, so that the reflex will be stopped and the valve mechanism action will come into play. Then, if the VUR is not there, MCU is very clear, then we have to see whether it is if the child is a male child, we have to see whether there is a phimosis is there or not. If there is a phimosis, then we have to do a circumcision, because the organism growth around the perpusal skin might enter into the urethra and might lead to urinary infections. And mainly we have to understand the mechanism why the urinary tract infection occurs in children, and how about, because we should not take it all the urinary tract infections very seriously, and at the same time you should not make it as a very simple thing, and we should not neglect it, because if as I told you, vesicoureteric reflux, it is a grade 5, and we have to do another scan called nuclear scan, that is called DMSA, that is dimercaptosuccinic acid, that is a nuclear scan, which is a dye we inject into the intravenous system, and it is being captured by a gamma camera. It is also very non-invasive. It is not a very cumbersome to the child. We have to put in the injection and give it. That's it, and that will pick up the kidney functions and scarring also. If the function of the kidney is low, then only we need to decide on the surgical interventions. So this is how about the overview of the urinary tract infection in children, and mothers have to understand what are the clinical symptoms, and how to go about it, how to collect the urine sample clearly and which should not be contaminated, and when it should reach the lab also. Then nothing to worry about urinary tract infections, unless otherwise it is a recurrent urinary tract infections in children. So this is all about urinary tract infection in children. I'm sure that everyone will be having a lot of queries about urinary tract infections. Your children might have it. If you feel anything to be asked to me, you can very well free to mail it to me. My email address is over here. You can mail it to me at any time. Thank you.